We're going up and down, over and over, over and over. It's the same old thing. Up and down, over and under.
All right. Well, Dr. Collins, welcome to the show.
Thank you. Glad to be here.
Yeah. Excited. We were just catching up. You're actually somewhat in my backyard out in Pittsburgh. So,
3 hours away, 4 hours away, something like that.
You know what? People don't appreciate how big of a state Pennsylvania actually is. Yeah. It is no joke getting from east to west.
When you drive on the highway or interstate, it's like it says Williamsport for like 80 miles. I've noticed that. I don't know if you've noticed that, but I have.
I have noticed that. Well, I'm really excited about having this conversation. We were introduced by a mutual friend, Frank Spino. Thank you, Frank. And I'm so fascinated by the work that your team is doing. And as a former college football player, I'd be lying if I said this wasn't something that was top of mind. You know, what sort of impact and lasting impact do concussions have on people who've sustained them? But maybe a great place to start, you know, I get the sense, and some of this is just based on, you know, my own experience, but in talking to other people, it seems like there's a lot of existing either misconceptions or misunderstandings as to what a concussion actually is. Could we just open it up by you kind of defining like what a concussion actually is?
Yeah, the word concussion or concussus literally translates from Latin to English to mean to shake violently. And think about your brain as like an egg inside an eggshell. And the brain is encased in cerebral spinal fluid. And if there's enough biomechanical force, either linear or rotational force, the brain's going to shift inside the skull. No matter how good your helmet is, the brain moves inside the skull. And if the brain moves violently enough, everyone on this podcast will hopefully know what a neuron is. So we have billions and billions of neurons in our brain. There's more neurons in our brain than there are stars in the sky, literally. And what causes concussion is when the brain moves in the skull, the membrane to the neuron will stretch. And this little chemical called potassium, which is supposed to be inside the cell or neuron, will get leaked out into the extracellular space. And when potassium goes outside of the cell, there's an increased demand for glucose or energy. It's called hyperglycolysis. So the cell's demanding more energy. And at the same time, this little chemical called calcium, which is supposed to be outside the cell, will leak across that stretched membrane and go into the cell. And when calcium goes in, we get constriction of our blood vessels, vasoconstriction. And at the very time we need more energy, we actually get reduced cerebral blood flow and less supply of it because blood supplies energy to the brain. And at the end of the day, all concussion is this energy crisis that causes the cells to not work as efficiently as they should. And what we've now learned is that there's different systems in the brain that can decompensate from that energy problem. And we've actually learned now that there's different types of concussions. There's actually 6 different types.
Oh, interesting. Yeah. Could we, well, and you know, I've read and heard a little bit that like plaque buildup can be one of the contributing factors to long-term effects. Is that accurate? I noticed that
we don't know yet. There's a lot of what you're going to hear from me today is that I feel concussion is a highly treatable injury. I really believe that if you come to our clinic, or if you go to a specialty clinic, there are treatments that can be applied that treat these problems, and you don't have to live with these symptoms and difficulties. And really the best way to prevent problems with concussion is to manage it effectively when you have one. Yeah. And to make sure that the injury is resolved before one goes back to playing, gets hit again. And that's easier said than done because of awareness. But the reality is this is a treatable injury. And a lot of people aren't aware of that. That's one of those misconceptions that you brought up earlier. Yeah. Everyone, I mean, I think there's a lot of sort of confusion out there about this injury, and hopefully I can set the record straight on some of these things today.
No, that'd be great. And maybe I cut you off a little bit there, but this might be a great dovetail into those, better defining the 6 types of concussions.
Yeah. So there literally are 6 different types of problems that we see after concussion. There's 6 different types of concussion. If you think about these, all these 6 things as 6 interlocking circles. So you can have one of these problems, you can have all 6 of them. But the 6 different types, the first type is cognitive, or cognitive means thinking. We can see thinking changes, memory, attention, concentration, and the actual type that we call that concussion is cognitive fatigue. So not only do we see cognition issues, but a lot of fatigue by the end of the day. The second type of concussion is a problem to a system called the vestibular system.
Mm-hmm.
That's the part of the brain that allows us, it begins in the inner ear, and then there's all these pathways of the deep part of the brain. And that system allows us to stabilize our vision. We move our head. It allows us to interpret motion. It allows us to be in a grocery store, car ride, shopping center, party, dynamic exercise, anything that involves a lot of sensory integration, lights, noises, movement, people, or movement around you, or you are moving around something. That system, because concussion's an energy problem, that system can decompensate. And when it does, the athlete will feel like this weird, slow, wavy, dizzy, foggy, kind of one step behind, detached, removed, disassociated. Busy environments will bother them, etc. Lights, noises, movements, that kind of stuff. That's an important one, and I'll get back to that. It's one of the more common ones that we see. The third type of concussion is ocular, which means eyes. So your eyes have to work together as a team. It's a very complex neurological system. In fact, 60 to 70% of the cells in our brain are devoted to eye movement.
Interesting.
And so that system is the most complex neurological system that we have. So it would make sense that an energy problem in the brain would affect that system.
Yeah.
And that would involve people having a hard time having their eyes move together, follow a target, converge, diverge, accommodate. There's a lot of different oculomotor functions that can be compromised as a result of this energy crisis that we see.
Yeah.
The fourth type of concussion is migraine, which by definition is headache with nausea and or light or noise sensitivity. Typically, migraine headaches occur more commonly in the morning. And headaches associated with vestibular problems occur more commonly in the afternoon. There's a lot of little crumbs that if you understand this injury like I do, you can follow these crumbs to figure out what's going on and get the right treatment for the right problem. But migraine is, that's the one probably people are most common with. The fifth problem that we see is neck issues, cervicogenic, neck problems that we can see from head trauma.
Okay.
And the sixth subtype is mood issues, anxiety, a lot of anxiety, difficulty turning thoughts off, rumination, hyper-analytical, panic, sadness, hopelessness, depression stuff. And think of these all as 6 interlocking circles. So there's a lot of sort of biology between these circles. For example, the same pathways in the brain that subserve the vestibular system subserves our sympathetic nervous system. So people that have a vestibular problem will get anxious. Their thoughts go faster, their heart rate increases, they feel this sort of arousal that's unpleasant to feel. People that have anxiety are more likely to have migraine. People that have oculomotor issues are going to have cognitive issues. People that have anxiety have cognitive issues. People that have anxiety have neck issues. So you can see how this might start with one of these circles, and if it's mistreated, it can spread to the other 6 circles pretty quickly.
Well, and what's interesting is, again, I can't remember if we talked about this when we started, but I played college football, and I can identify clearly at least 2 to 3 significant concussions, one of which I sustained in college. And as you're kind of walking through this list of those 6 interlocking rings, I'm like, I kind of had a little bit of that.
Why don't you walk me through, Ken? Let's go through and what did you experience when you got hit? Do you remember what you felt?
I do. So, it's funny because you've mentioned a couple things now that are making a lot of bells go off, but we were doing like the Oklahoma drill. So I was going up against our middle linebacker. I was a running back, had like a head-on-head collision and just felt really kind of woozy and off, right? Enough to where it was like I got pulled out of the drill.
Can I define that a little better? You tell me if I'm right. So when you say that, it makes me, you feel one step behind, detached, disassociated, sort of
disoriented for
sure.
That is foggy.
That's the
foggy
term
comes to mind.
that we call foggy. And that is the vestibular system decompensating from that energy problem. So when that system isn't working efficiently, it will literally feel like you're one step behind, detached, and sort of it's like taking a lot of NyQuil and waking up in the next morning. You just feel that haze, that foggy feeling. And that is literally at that moment is when your vestibular system decompensated and didn't work as efficiently.
Yeah. Well, and you know, to take that a bit further, and I can't remember how long I got pulled out for, and I definitely don't want, you know, I mean, a lot has changed since I played, but what really kind of did me in is I think less than a week later, I was back on the field, and I kind of got horse collared from behind, and I got my head driven into the turf, and that experience was different. Like I don't remember anything for the next couple minutes,
So that's the cognitive stuff that's going on there.
Yeah, and the symptoms that kind of came out of that was one, I watched myself back on tape, and luckily someone pulled me out because I clearly had no idea what was going on. But then, days, maybe a week. I couldn't read a book and get through a sentence without having to go back to where I was.
That's very likely oculomotor. So that's very likely your eyes were not normal, because it was engaged when you were trying to read. And typically that's associated with like a frontal headache. You get really tired. You can't focus. Yep. Math is harder. Science is harder. Classes that have a lot of visual, spatial kind of functions are more difficult.
Mm-hmm. Yeah. So, it's making me kind of like think through all the various symptoms. And maybe it's because, and you mentioned this too, it's like, hey, how quickly can we identify and start treatment makes a big difference. The fact that maybe I definitely returned too quickly, and that initial impact didn't heal.
I can tell you the good news is that you didn't have the same symptoms the second one as you did the first one. And so that would not indicate to me necessarily, I'd have to evaluate you.
Sure.
But, normally you can get in trouble with this pretty quickly if you're not recovered and get hit again. And then you go down that pathway further. Now, the good news is there's treatments for this. Like I can treat everything you just said. We actually have treatments for it. And that's another misconception that people aren't aware that there's actual therapies for these problems, which there are.
Yeah. Could we dive into that a little bit? Because I think, and again, to give you more context, so I was playing from like 2006 to 2010, so when this happened, it was over 10 years ago. And at that time, I think the treatment was, rest, no contact, which, I mean, that clearly makes sense, but I would love to kind of hear, just like based on those initial explanations of what I was experiencing, like what are the sorts of treatments now that people who experience concussion could potentially use? So
we actually have tests that we would run on you. So that first injury you had, I actually have a physical exam that I would conduct on you to see if there's I'd listen to your symptoms, get an idea of what's going on, and then I actually have a physical exam I could conduct on you to elicit if there were problems coming from the vestibular system. Okay. And once we identify what those problems are, the first thing is when in doubt, sit them out. You don't put those patients back to play.
Yep.
Make sure they're seen by a specialist that has the right tools to look at this. We actually can quantify this and measure it. We can look at it and see it. Now, so with that being said, the treatment for a vestibular problem is actually rest is the worst thing you can do.
Interesting.
Because the way we treat that problem is by training it. Okay. But because the vestibular system is linked in with the nervous system, it will make you feel anxious when I do rehab with you. And a lot of patients will start to avoid activities that produce symptoms. Like a grocery store, for example, is a great example of an environment that's very difficult for someone with a vestibular problem. A party, a restaurant, exercise, movement. They will get dizzy, they will feel foggy, they will get headache when they do those things.
Just a bit of like sensory overload, sight, sounds, a lot of...
Correct. But the way you get better from that problem is by training it. So actually going into a grocery store is the right thing, but your nervous system is telling you not to do that. Patients that don't get the right treatments and get told to rest, they start limiting those activities, and then they lose outlets to get rid of stress, and the stress will build up and up and up and up and up, and then that can produce migraine. So
interesting.
And we treat migraine with activity and exercise. And so you can get in trouble with this injury lickety split if you don't get in the right pathway for treatment.
Yeah.
We just published a study in JAMA where we looked at all the factors that predict outcomes from concussion. And believe it or not, the biggest risk factors for having a longer outcome from concussion is history of car sickness, history of lazy eye, history of anxiety, history of migraine, being female. These are all risk factors that have a longer outcome. But the risk factor we found that best predicted poor outcome was if it took longer to get into our clinic. If you can get into our clinic within a week, your outcomes are like a quarter of the time it would take to recover if you don't come into treatment.
I read that. And why is that? Is that just because
you get patients in the right treatment? And you got to make sure that you assess this injury properly so you know what's going on, and then get them to the right treatment. So every one of those circles has different treatments for it. And this is not about protocol, it's about process. And when I hear the concussion protocol, it sends shivers up my spine, because it's not about protocol. Every case we see is different, and every case has to be managed differently. And because of what you hear on TV about the protocol, everyone wants to stick to this one-size-fits-all approach, and it's not effective, and it needs to be individualized.
Yeah, I think, even for me, I guess I never thought about it in terms of an injury the same way you might treat, a more traditional, like, physiological injury, right? Like, pull your hamstring, like, hey, there's treatments and things that you can do to improve it. I felt like my experience was much more like, hey, we just got to kind of wait this thing out. And we'll continue to test you consistently to see when you get back to a baseline cognitive level. I
actually really like the analogy of this being, now, look, this is going to rub some people the wrong way, but it's true. It's like, I look at this as an orthopedic injury. Like, we've gotten to a point now with our treatments, like with a knee injury, this is the type of knee injury you have. This is the rehab we have to do to correct that problem. This is how long you're going to take to be out of play. And when you're recovered, you're going to be safe to go back to play. That's exactly what we do with concussion now.
Wow.
This is concussion. This is the type of concussion. This is the active and targeted approach we're going to take at treating it. This is your rehab program. And this is how long you're likely to be out of play. We can treat the injury in that fashion. And if you treat it effectively, we can mitigate the long-term problems from it.
Yeah.
And it's critical that patients and parents and athletes are aware that these advances have occurred, which they have.
Yeah. Well, and maybe just to take this one step further, is it the sort of thing where you have a window of time where that treatment can be effective? Because I imagine there's a lot of people that, like me, played 10, 15, 20 years ago, or were in the military, or got in a car wreck, or, any other reason that someone might sustain a concussion. Is there still an opportunity to do some of this rehabilitation, or has that window kind of closed?
No, it's not closed. We see patients. I just had a busy clinic this morning, and I saw an NFL guy that was injured about 18 months ago, kept playing through it. And we were able to identify his problem today, and we'll be able to treat it, and he'll be normal when we're done with him, and he'll be okay. It's not uncommon to see patients that have problems months out, even years out, where we can identify where that's coming from and actually get them better. This really is treatable. There's always reasons for people feeling the things they're feeling. And it's our job as clinicians to identify where the aberrant signal's coming from, and then apply the right treatment to correct that problem. Yeah. The great majority of the time, we can do that. Now, can I tell you we can treat everyone fully 100%? I'm not going to say that.
Sure.
But I feel that way every time I see a patient. There's never a patient I don't feel I can treat fully. I'm sure there's cases where it's happened. But we'll do everything possible to get them better.
Yeah. No, I think that's encouraging. And you mentioned too, right? A lot of the conceptions, that people are aware of with regards to concussions, oftentimes make their way to the general public by the NFL, right? So concussion protocol, I think the other topic of interest over the last 10 years plus has been this idea of CTE. Is that something that you would say falls within that same realm of, hey, this is an injury that can be treated, or is that kind of a completely different animal and it's worth,
so I think a lot of people
differentiating the two?
I think a lot of people are confused by this construct. And I'll be honest with you, as someone who does this every day of my life and has devoted his entire career to studying this problem, it's confusing to me too, because the science isn't clear on it. We don't know if concussion in and of itself is what's causing that tauopathy and the protein buildup and things that are being seen. We don't know if it's concussion plus X, Y, or Z, or we don't know if it's X, Y, and Z and not concussion.
Yeah.
And so the science hasn't evolved to the point where we really can fully determine cause and effect relationship to this. And I'll be honest with you, it doesn't match my experiences, because the great majority of people that leave our clinic are people that get better, and we get them back to play safely, and they look and feel great, and they're not reporting problems after we get them back to play. So it's a little bit of an enigma, because I think that we need better diagnostic clarification for this construct. We need more science. Fortunately, that science is being done currently.
Yeah.
And the scientific story is not written on this construct yet. We have one of the largest studies ever done looking at a bunch of former NFL players and controls and seeing what the potential long-term effects or on neurological health there are from playing football. That study's ongoing. I don't have data to report on that yet. We're collecting it. Yeah. But it's the most rigorous methodologically controlled study that's been done in this space. And we're going to have answers very soon in terms of what the potential, I underscore the word potential, effects of playing football are on neurological health. Yeah. But that study hasn't been done. And so we're left as clinicians to not have answers for our patients. Again, that same guy I talked to you about this morning that I saw, I was like, well, if I play one more year of football, what's my relative risk of increasing my odds of having neurological problems? And I'm like, I can't answer that for you. And that makes people uncomfortable. But that's the reality right now. There's no one in the world that can answer that question.
Yeah.
What I feel is that the tools that we've developed to measure this injury are highly effective. Yeah. We can see if there's problems with patients. And fortunately, we found that we can treat those problems a great majority of time. And so what I'm hearing in the media doesn't correlate with my experiences with this injury, because we see people get better from it. Yeah. And you don't want to be cavalier and put someone back to play if there's risk there. We just need better science to better understand these issues. And that science is not currently available.
Got it. Yeah. I mean, as someone who played football, this is clearly something I think about. And then I have, 3 young kids, 2 of which are boys. One's 4, one's 2. So I feel like I have hopefully some time for the science to catch up and there to be more clarity. But I would be lying if I said like, wow, I'm now knowing what I know now, I'm a little, concerned as to whether or not it's in their best interest to let them play football. And again, for me, right, a sport that I love dearly and probably created a lot of opportunities for me that I wouldn't have had otherwise, right? So, what would you say to parents out there? Not that you need to be the one to convince them whether or not to play football, but like, what are the sorts of things they should take into consideration when making that decision? Like, are there resources you can point them to?
Yeah. I actually have parents that will come here for me to evaluate their children to see if we know there's certain risk factors for having longer outcomes from concussion. Mm-hmm. We know, long story short, to answer your question, I'm a dad of 4 daughters. If I had a son, I'd let my son play football. Without question. I think there's so many benefits of sport for children in terms of physical activity and teamwork and all the things that you learned in football and applied to life. That opportunity exists for kids that play the sport. And right. Like I said, we see football players every day here in our clinic, and there's very few that walk out of here sick or not normal and not doing well. I do feel it's a treatable injury. And until proven otherwise, I don't think those patients are going to go on to have problems from playing, because we know it can be treated. Yeah. And so my advice would be, I think football is a great opportunity, but make sure if there's symptoms of concussion, be knowledgeable about that, be aware of it. You don't want to play through this stuff, and make sure these kids get to a specialty clinic like at UPMC here, where we can evaluate and treat the injury properly. Because the best way to prevent problems with concussion is to manage it effectively when you have one. And it can be fairly tacit, and and a lot of kids don't even know they are concussed. It's very subtle, some of these symptoms that can happen. Right. But my advice is I think sports are wonderful. I do have 4 daughters that play sports, and 3 out of 4 of them have had concussions, and we treated them, and they're doing great.
Well, that's what I was going to ask you next. You know, I know football, rightly or wrongly, is often the poster child for concussions. But within like the realm of your practice and at UPMC, you know, I mean, is it truly, it's like, hey, the majority of concussions that walk in the door are from football, or concussions being sustained across a wide, diverse array of just sports and just general, you know, everyday life?
60% of my patients are female. Females are more at risk to sustain a concussion and have a worse outcome from it.
Interesting.
There's migraine is a big risk factor for concussion, and females are 6 times more likely to have migraine than boys. That's likely the very reason why that happens. There's hormonal issues that we've shown to occur that pose some risk for females. Neck strength, their necks are not as strong as males. So car sickness is more likely to occur in females than males. Yeah. These are all risk factors. So that's why girls are more likely to have concussions. But I mean, yes, we see a large number of football players here. You can expect, and according to our research, about 1 out of every 10 football players will have some symptoms of concussion during the course of a season. 10%. And, you know, female hockey is maybe the highest risk sport there is. Soccer. If you compare females to males in soccer and hockey, it's the same sport essentially. And you can compare, you know, it's apples to apples comparison. Females are much more likely to have concussion than males than those sports. So yeah, football, I mean, any sport where there's force and, you know, force equals mass times acceleration. So, you know, this can happen in a number of ways. For my girls, they're basketball players. It was back of the head off the court, you know, for a loose ball every time. In soccer, one of my girls got in soccer, you know, he got blasted from 10 yards or whatever. But this stuff happens, and it happens across. It's not only sports either. It's slip and falls are very common in older folks. Car accidents, obviously. You can get domed in a number of ways, and we see it, unfortunately. A lot of people with a lot of different types of injuries. I have some very interesting stories about that whole thing, but it's a fascinating job.
Oh, I can imagine. Yeah. Well, you know, and that's the thing too. Like I can think anecdotally about all the ways that I've knocked my head over the years. Some certainly football, but some other, you know, just like I said, everyday life. Well, one of the things that we've kind of focused on so far is, you know, once you've sustained a concussion, best course of action. And if I'm not putting words in your mouth, it sounds like it's identification of a concussion as quick as possible is key to recovery. And then finding the appropriate treatment with a specialist, with someone like yourself.
Being aware of the subtle symptoms of injury. And just one quick thing, you know. Yeah,
please.
Our research shows that on-field dizziness is 6 times more predictive than any other symptom in predicting worse outcome from concussion. And being dizzy is 6 times more predictive of poor outcome than losing consciousness. Can you believe that?
Wow. I'm glad you brought that up. So if someone gets knocked out, does that inherently mean that there was a concussion?
Yes.
Okay.
Yeah, unequivocally, if you get knocked out, you got a concussion. Yes.
Got it.
But also, if you have dizziness on the field, nausea, light sensitive, noise sensitive, headache, fatigue, you know, vision changes, feeling foggy or detached, one step behind, those are all clear signs that a concussion has occurred. And other things can cause that too. But like I said, when in doubt, send them out. And if there's been trauma and those symptoms are occurring, don't put them back to play. This study will be very interesting to you. We looked at kids. We looked at a very large cohort of kids, I think around 500, 250 of whom had symptoms of concussion and came out of play immediately once their symptoms occurred. Okay. And then half the sample had symptoms of concussion and played only 15 minutes longer with those symptoms of concussion. The kids that came out immediately recovered in 19 days in terms of their concussion. The kids that continued to play for 15 minutes recovered in 44 days.
Wow.
So playing 15 minutes longer with having symptoms of concussion added almost a month of recovery.
Do we know what that's attributed to?
Because these systems that decompensate, the vestibular system, if that system decompensates and you overtax it, it can lead to migraine. It can lead to a lot of different things that add more time onto your recovery. It can further decompensate the system. And so it's very important that to recognize this injury and to get kids out of play immediately. Now, those same kids that took longer to recover, if they receive treatments, they can get better much faster through the physical therapies that we've developed in the rehab. We've developed rehab for all these problems.
Yeah.
And so you don't have to take 44 months if you play 15 minutes or longer, but you need to be seen by a specialist who can treat this stuff and apply the right treatments for it.
Yeah, I think that'll probably be eye-opening for a lot of people. The thought that it can be rehabbed, right? And that there's an actual treatment and it's not just time.
Yeah, no, with this injury, with the vestibular subtype, the ocular subtype, and the migraine subtype, and even the anxiety subtype, we can actually treat this with certain types of rehab and treatments. Like for vestibular therapy, we have physical therapy. I mean, for vestibular problems, we have physical therapy exercises that retrain that system. Mm-hmm. We actually have workouts that we can give patients that retrain that system. You come see me, I'm going to work you out, even if you're having bad headaches. We actually work people out to get them better. Exercise treats this stuff, and you just have to do it in a very targeted and prescriptive way. You got to exercise them correctly.
Yeah. I don't even know if this is worth mentioning, but it's interesting. I felt like, again, that 2006 to 2010 timeframe, there was kind of a shift in perception that had happened with regards to rehabilitation, away from sheer just rice and rest, and that it was actually beneficial to go in and attack the injury, quote unquote. Right. So if you had some sort of like major contusion in your leg, right, rather than avoiding it and just giving it rest, like you're actually going to recover much quicker by going in. It might be more painful, but doing some dedicated work on that area and around it. And because of that, right, you would recover faster. This is kind of triggering that same aha moment I had back then.
You kind of, again, it's a great parallel, the orthopedic model of care. And it's not irony that I work in orthopedic surgery. I'm a neuro guy working in orthopedic surgery, and I've worked alongside I'm in sports medicine, so I've worked alongside our sports medicine physicians and seen what they do in treating orthopedic injuries. And quite honestly, I've been doing this for 20 years now at UPMC. Yeah. And we're applying those same principles to concussion. And we're proving it through randomized controlled trials, and we can treat this stuff. Yeah. And it's a very similar model like you described. And yes, we do provoke symptoms to treat it.
Yeah, I think it's both eye-opening and hopefully encouraging. One thing I wanted to ask you, a lot of what I've been asking you about today is, hey, from the moment that a concussion occurs, like what can be done? And I think you even said as much, like the best prevention is either proper identification or proper management of the symptoms. Am I saying that correctly? Yeah. Given your focus on the brain, neural pathways and all that, is there anything that you recommend in terms of a best practice to kind of just optimizing brain function on the front end? So I would love to hear like, hey, stay hydrated, that maybe that'll reduce your risk of concussion. Or if it's
I actually can describe to you a model that I think is very effective. So, okay. So let's talk about, let me just go off beat here a little bit. So the migraine is a threshold problem. Okay. So anyone that falls below this line will have a migraine. Anyone that's above it won't have a migraine. And that's the way neurological problems exist, as thresholds. Alzheimer's disease is the threshold problem. Yeah. So people hopefully are up here and off the line with migraine. Okay. Right. There's 5 things that cause migraine in patients. And if you do these 5 things poorly, you will get a migraine, guaranteed. What they are is if you take naps and don't have a consistent sleep schedule. So if you nap, or you sleep in 2 hours longer than you should, or go to bed 2 hours earlier, if you pick a bedtime and a wake up time and you don't nap during the day, you're going to stay up here off that line. If you nap, interesting, you're going to go down here. Okay. Okay. The second thing that predicts migraine is if you're not exercising. Third thing is if you don't eat 3 meals a day at the same times. Fourth thing is if you don't hydrate well. And the fifth thing is if you're stressed and have internal stress. People that don't express stress well, that they have this internalization thing where they hide stress really well, those are people that pop a migraine. So those 5 things also serve as a threshold for injury for concussion. So if you are stressed out to make the team, you're not sleeping consistently, you're not exercising before training camp, you're sitting here, you get hit in the head, Yahtzee. Wow. If you're doing all those things really well, and you get hit in the head, you don't feel anything. And so we there's different thresholds for concussion that exist depending upon those lifestyle factors. And so think about training camp. When you went to training camp, Princeton, okay? Maybe, you're third man on the depth chart, and you're stressed out about getting above to number one. Yeah. And you got internal stress. You don't want to show stress. You're just wearing it inside. You're not vocalizing, you're not articulating it. You're just swallowing it because you don't want to show weakness. Let's say you took 2 naps 2 days before training camp started, or you had to wake up at 5 a.m. when you've been waking up at 8 a.m. all summer. Okay. Yeah. Let's say that it's 101 degrees out and you can't hydrate well enough. And no matter how well you hydrate, you're going to be dehydrated. Let's say that you skip breakfast. Those factors all put someone right above that line, and you get hit in the head, you're going to go over that line much easier than if you can do these other things. So there are ways to prevent it from happening. And those things I just mentioned are things we've learned very clearly predict who gets a concussion and who doesn't.
Oh, wow. It's funny. The themes that keep popping up, the more I do this podcast, sleep and stress come up more than any other, and in ways to like, I did not anticipate that our conversation would kind of go here today, and that those two factors maybe, you would identify as having a potential impact on increasing your likelihood for a concussion. But those two things continue to pop up time and time again, which I just find to be interesting.
Well, I can tell you that stress plays a huge role on your bodily functions. There's a lot of physiology behind stress and physiologic difficulties. Yeah. And there's a lot of relationship between stress and physiologic difficulties. Yeah. If you don't treat stress properly, you're going to have belly stuff. You're going to have headaches. You're going to feel tired. You're going to get dizzy when you stand up quickly. You're going to get lightheaded. You're going to have cognitive issues. You may have vision changes. There's a lot of things that can occur with stress.
It's funny. We're literally, and this always seems to happen. We're talking on a day where I've been up since like 3, and I've probably had one of the more stressful work days that I've had in a while. Right. So it's just the irony is too much to notice.
In other words, you have all those things going on right now, is what you're saying.
So I'm just avoiding contact like the plague today. Let's put it that way.
Good idea. Yeah.
Yeah. Is there anything that you're interested in? I get now that we're kind of venturing a little bit away from the concussion discussion. Boy, no pun intended. Is there anything like nootropics, right? When you start thinking about human optimization, that's something that is really gaining a lot of steam and a lot of interest. Are those things that your practice is paying attention to at all? Or
we haven't learned of any supplements, nutritional advances that prevent this from happening. And quite honestly, I don't see any relationships, we don't delve into that as much, and just like orthopedics, maybe that's the next frontier, looking at some of these things. But no, to answer your question, we haven't found any relationship between that and thresholds or problems.
Yeah. Yeah. One of the things that I was interested in is, I believe it's a recent study that you conducted, and it kind of got my wheels spinning around some of the testing that you're able to do nowadays. It was a test, I believe it was like biomarkers in saliva. Does that sound accurate to be able to?
We're doing a lot of work in that space. Yes, we're everyone wants a biomarker for concussion. I'll be honest with you. We've been looking for a biomarker for Alzheimer's disease for 4 decades and haven't found it yet. So don't think there's anything around the corner. Yeah. But we are looking at, there's a whole panel of biomarkers that we're examining to see if they're effective at predicting concussion and outcomes. And we've yet to find one. In fact, all these, the pathophysiology I talked about earlier, we don't see it on a CT scan or MRI. There's no imaging modality that we can use to show concussion at this point in time. Right. So there's nothing, we have to measure this through other ways. And we've developed tests like the impact test, which is a computerized neurocognitive test that can measure cognition following concussion, baseline testing, that kind of stuff. It's very effective and very helpful. We've created an exam called the vestibular ocular motor screening exam that we can use a physical exam to measure this stuff. But right now there's nothing, from a biomarker standpoint that's ready for prime time.
Yeah. again, one of the things that now I'm just like almost embarrassed to say this. I remember the mentality was such when I was playing that when we were going to go in and do like our baseline testing, right? The kind of like the word on the street was like, hey, sandbag it a little bit.
Sure.
Lower your baseline so that once you take this test, God forbid when you need to, you can get back on the field the next game.
Even though you went to Princeton, you weren't very smart because,
no.
First of all, that would be something that would be kind of stupid to do. But beyond that,
you can say idiotic.
Yeah, it is.
Now I
played sports. Ridiculous. I get it. I would have done the same thing. Yeah. But we actually have measurements inside the tool that show someone that's doing that. And we have studies that prove that we can, it's very hard to do that and not be picked up on the test. There's statistically, we know exactly where someone should be. And there's areas that people try to fake bad on that it actually shows in the report that they're faking bad.
Raises a red flag.
Yeah. And then what ends up happening is it literally will get flagged. And then the baseline's invalid. And we always have a higher standard if we don't have a baseline to put someone back to play. Yep. So you just kind of screwed yourself because you're going to actually probably have to do better than you would have had to do in the first place.
Right.
So it's not real smart. And we've shown that the studies have shown that we're up to 80 to 90% effective at picking up on sandbagging. So
interesting.
Yeah, it's hard to cheat the test and us not know about it.
Yeah. Well, that's good to hear. And again, I think, part of it is just being a stupid 18-year-old kid. Part of it was just, I don't think there was as much awareness around repercussions and, the magnitude of, what a concussion could do if untreated and then played through.
Yeah. The cool thing is hopefully athletes get in this mindset. Okay. Like if they have knee pain and they're wondering what the hell's going on, right? I've got knee pain. I need to get this evaluated. Like, people aren't scared to do that because they want to know what's the effects. Like, what am I going to do to myself if I keep playing? Is it going to get hurt worse? Right.
Yeah.
Like, liken that to concussion care, like come in and get evaluated if you're concerned. There's things we can do. And I'm the most aggressive guy you'll ever meet about getting back to play. I'm not fearful of this. I feel it's treatable. I feel we can get kids back to play safely. I'm very aggressive at getting patients back to play if I know they're safe to do so. I'm the biggest fan of sports there is, and it's all about getting kids back to play. That's the goal. And and we're not going to put you in dark rooms and stuff you in a closet to get you better. We're going to actually actively treat it. We're going to rehab it. Yeah. And so as this takes hold with all the research that's being done and the awareness and that people are aware that if this is new information for people, I hope it gives them confidence that, look, we're actually treating this pretty effectively now, and report your injury, and you're going to actually prevent poor outcomes from happening. Yeah. Just like you would a knee injury.
Yeah. No, I'm glad to hear that. Again, with 3 young kids and they're starting to play sports, and whether or not they play football, right? I mean, if you're being an active person and you're engaging in a sport where, like you said, bodies are moving quickly, there's the potential for concussions to happen. But I also don't think the flip side of that is putting them in a bubble and protecting them from everything is any better. In fact, I would believe that's worse. So it's kind of like weighing the risk reward.
If you listen to my talk earlier about thresholds, people that get put in a bubble and aren't allowed to do things, they're highly anxious people, and they're going to be sitting right above that line. So your risk of injury is going to be much higher than someone that's playing football and not having that bubble.
Interesting. Well, thank you. This has been an incredibly, hopefully eye-opening and hopefully inspiring conversation for a lot of folks, especially if they've either dealt with a concussion, or just are concerned about, what are the long-term effects and what is the treatability of it if they or a loved one ever sustains one in the future. I guess, for those who do want to find more information, where can I point them?
We have a very good layperson website that outlines some of the things we talked about and there's good information on there. It's www.rethinkconcussions.com. And we called it Rethink Concussions because there's a lot of, we try to dispel the myths that are out there on that site. And there's a lot of really cool information about, our clinic and patient care and and, vignettes, clinical vignettes and cases that we've seen and treated, and research and all the things that go along with a good academic program. So that would be the site I'd recommend to go to. There's a lot of really good information there.
Oh, excellent. Well, perfect. Dr. Collins, this has been a really good conversation, and thank you for making the time.
I enjoyed it a lot, Ken. Thank you for having me. Appreciate it.